Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bienvenue, bonjour, welcome, and hello. My name's Doug Archibald, and I am the Director of Research and Innovation for the Department of Family Medicine here at the University of Ottawa. And thank you for being here today for what it promises to be a very exciting September edition of Family Medicine Grand Rounds. Just heard on the weather today that tonight at around 9 o'clock will officially be the first day of fall. So please find some time today to get out and enjoy the last day of summer. Now, before I introduce our speakers for today, I just want to introduce the coordinator of Family Medicine Grand Rounds, and that's Mia Ismailova. Mia is going to be your point of contact if you're doing any future Grand Rounds presentations, and she ensures that everything that goes on today happens smoothly. So welcome, Mia. Today's speakers, as I said, very promising, engaging session today on practice patterns for early clinicians, early career clinicians. And our first speaker today is going to be David Rudoler. And David is an assistant professor at the Faculty of Health Sciences at the Ontario Tech University. He's a quantitative researcher with expertise in health policy, health services research, and health economics. His research focuses on the evaluation of policies and programs that impact primary and mental health service delivery. David teaches and supervises students in the Bachelor of Health Sciences, the Master of Health Sciences, and PhD programs in the Faculty of Health Sciences at Ontario Tech, and the Master's and PhD program at the Institute of Health Policy, Management, and Evaluation at the University of Toronto. After David's presentation, we'll have some time for some question and answers. And then our next speaker will be Dr. Agnes Grudniewicz. And Dr. Grudniewicz is an associate professor at the Telfer School of Management here at the University of Ottawa. And she's a quantitative primary care researcher with a focus on patients with complex health and social needs. She teaches in the Masters of Health Systems and PhD in Management and the Masters of Health Administration programs. So David, I'm now going to hand the floor over to you. And you can share your screen and begin.
Just going to jump right into it since I only have 20 minutes and I'm hoping that I can fit this in. But this is some work, Agnes and I are presenting some work that we've done with colleagues from across Canada on practice patterns of early career primary care physicians. So we have principal investigators and clinician researchers and other collaborators from 4 provinces, British Columbia, Ontario, Nova Scotia, and Manitoba. And in each province, we've applied the methods that Agnes and I will be talking about today. So just to say that this is work that Agnes and I are representing this team, but this is not our work alone. So just to set up the rationale for the study, there are 2 conflicting views of the supply of primary care services in Canada. We know that the supply of physicians, so individual physicians in the labor force, has been increasing relative to the Canadian population over time. So family physicians per capita has been growing. Yet we know that many Canadians have challenges trying to find a family doctor. There are a number of people who report not being able to find a doctor at all or have challenges accessing primary care. And one of the explanations for this, there could be many, but one of the explanations for this is that family physicians have over time, despite there being more of them, have changed the way that they've practiced primary care. And that this has contributed to, despite there being more family physicians, still challenges with access to care. And there is an added contention that there's a specific generation of family physicians that's largely responsible for this, that they're doing less of the things that are often considered core to primary care: comprehensiveness, continuity, accountability, and coordination. And you might guess who this generation is. It's the millennial generation, which people have their views about, clearly. I think this is subjected to every generation that has ever been, but being part of this generation, I feel particularly personally attacked. There seem to be some interesting views about the millennial generation. We don't like dry cereal, apparently. We're destroying the cereal industry. We have an affinity for avocado toast, and this last point about home ownership might actually be true. But I had dry cereal this morning. It was delicious, and it was quick, so I could get to this meeting on time. But more relevant to our study is this view that has been expressed explicitly or implicitly in some publications that have come out in Canada, not too distant past, about the practice intentions of early career primary care physicians and how they're moving away from, as I said, these core things that we consider to be part of primary care service delivery, particularly comprehensiveness and continuity of care. And so we set out to investigate this view in as much detail as we could, using 2 different approaches, a quantitative and a qualitative approach. So I'm going to focus my presentation on the quantitative half, and Agnes is going to tell you about what we found in the qualitative side of the study. But our main goal in the quantitative arm of the study was to compare practice patterns early and established family physicians, early career and established family physicians, to determine if their practice patterns have changed over time and whether these changes are unique to the most recent cohorts of family physicians. So to do this work, we used linked administrative health data from 4 provinces, BC, Ontario, Manitoba, and Nova Scotia. The databases we access for this work were principally registry files from provincial regulatory colleges, physician billing information, and patient registration files from provincial insurers. We included, the analysis was at the physician level. We included all physicians registered with their respective provincial regulatory colleges with a medical specialty of family practice, and or those who build the provincial health insurance system for patient care between 97, 98 and 2017, 18. So we have about 20 years worth of data here. And in terms of exclusions, we had to make some choices about who to include, who's actually practicing during this time period. And so we restricted our cohort to physicians who had more than 100 unique patient day contacts or had worked at least 50 days during each of the years of our study period. We also excluded physicians in any fiscal year where they had a specialty other than family practice. And in our quantitative analyses, at least thus far, our main outcomes of interest that we measured were just a measure of volume of services provided, obviously a crude measure of what physicians are doing, but one that was commonly looked at. So basically just number of unique patient-physician date combinations within physician billings in any given fiscal year in our study period. We're also interested in continuity of care, and so we used a measure of physician level continuity. This was the proportion of total annual contacts, excluding ED visits, that all patients seen by that family physician had with that physician. And then we also developed a measure of comprehensiveness. There's no one definition of comprehensiveness in the literature, and there are some challenges with developing a measure like this across 4 provinces with different billing information, but essentially we developed 2 different measures: an index of service settings, so how many different settings do physicians practice in, like home, long-term care, emergency department, and how many service areas within the 7 that we identified here, so things like pre-postnatal care, pap testing, mental health, etc. So I'm going to talk to you about 2 studies that we have completed, and I'm going to spend a lot more time on the first one. So if there are any questions, I'm happy to answer them at the end. So our main objective here is, I stated in the objective of the study, was to identify whether practice patterns, there have been changes in practice patterns over time, and whether these changes are unique to the most recent cohort. And to do this, we used age period cohort modeling technique. And essentially the goal of these techniques is to identify 3 separate effects. Age effects, so these are changes in that occur over natural life course. So as physicians go through their career, their practice patterns might change as they get older and closer to retirement. Then there are period effects. These are sort of exogenous changes that happen during at any given point during the study period. So it could be a policy change. For instance, the provincial government implements a new payment incentive for diabetes management, and this might change physicians' practice patterns, for instance, or it could be an economic downturn or something like that. Something that affects all family physicians equally at a given point in time. And then there are effects that are unique to specific cohorts of physicians. So people who started their practice at a given point in time might have different preferences for how they practice than physicians who might have opened their practice at a different time. And so whichever of these effects appear in the results, or we identify as having an effect on practice patterns, might imply different policy responses. So for instance, if we find dominant age effects, this might imply that workforce planning needs to account for the different practice choices that physicians make at different career stages and sort of the age distribution of the workforce. If it's a period effect, it implies a need for policy responses to respond to sociodemographic, economic, and political changes that might have occurred over that time period. And if it's cohort effects, it might imply that we need to implement some changes or interventions at the formative stages of physician training to maybe alter their practice patterns or career intentions. So there's a problem with identifying these three effects, and this is well documented in literature. And basically what all age period cohort modeling seems to focus on is this identification problem. So that is that when you subtract age from period, you get cohort. So it's perfectly identified. So you, in an ordinary least squares regression model, so a linear regression model, you wouldn't be able to estimate the equation with all three variables in your model because of the lack of ability to identify the three effects separately. And so in order to deal with this issue, the literature on age period cohort modeling talks about the various constraints that you can apply to this system in order to make it, in order to identify it. And I'm not going to go into too much detail about the technical components of this, just provide some of the intuition here, but essentially you need to make some, the literature talks about making decisions, particularly around what a cohort is, in order to identify which constraints are the ones that should be applied. And so there's an interesting article by Keyes and colleagues that argues that age period cohort modeling requires a core assumption about whether a cohort is defined as a first order effect or a second order effect. So a first order effect represents unique conditions that shape lifelong preferences. These are typically the things we think about when we think about cohorts. So there's something unique to people born, let's say, after World War II and they experience a common set of life experiences that changes their preferences and their decisions along their life course. And we made similar claims have been made about early career or millennial doctors about their preferences for not doing comprehensive primary care, for instance, that there's something unique to that generation of physicians that makes them want to practice differently than previous generations. Meanwhile, second order effects are an interaction between period and age. So there's some events that occurred that affect different age groups differently. So we can think about COVID-19 as being having different effects on school age children, for instance. And the choice about how we define cohort is purely conceptual, it's not empirical. So basically we have to base this on theory, and that's what a lot of the literature, particularly these two authors, Bell and Jones, who have lots of negative things to say about age period cohort modeling. And they basically say that your decisions around how to estimate these models or develop them should be based on theory and not and shouldn't be driven by empirical considerations, because your choices here can make a big difference. And they also suggest that you should focus where possible on second order effects rather than first order effects. And indeed, that's what we did. We made a decision as a team about our definition of what cohort was in our context. And we defined it as a second order effect. That is, that there were changes that might have occurred over the 20-year time period of our study that might have affected different age groups differently. And that implied a specific way of modeling the age period and cohort effects. And we chose a technique called the median polish analysis, which is largely a descriptive data visualization technique, but can be adapted for confirmatory analyses, which is what we did. And basically these models estimate cohort as an interaction between age and period effects by iteratively removing linear variation due to age and period. And then what remains once you remove the effects of age and period are the cohort effects. The residuals that remain are the cohort effects. And so we modeled these residuals as well as the age and period effects themselves. And so I'll just jump right into the results. So this is just a graph showing changes over time in each of the 4 provinces that we analyzed: BC, Manitoba, Ontario, and Nova Scotia. And it's showing patient contacts, average patient contacts between the first and last period of our study. And so we can see that in all 4 provinces, there was a decline in the number of contacts provided by family physicians during this time period. That slide was not supposed to be there, my apologies. This slide is showing the results of our median polish analysis, showing basically the same thing. So here I'm showing the coefficient estimates from a linear regression model with time period, the coefficients for time period. And so here we can see that relative to the first time period in our study, which are organized into 3-year bands, we can see that there were declines in each of the provinces. Sometimes these were statistically significant, sometimes not, but in all cases, there seem to be declines relative to the first period. When we look at age effects, and in our study, rather than use biological age, we used years in practice as our age variable, which for the most part maps on to biological age, but not necessarily for everybody. But basically what we're seeing here is what we might expect in terms of career paths for a family physician. We see that as physicians enter practice, and they work towards the middle of their careers, they increase their practice volume in terms of patient contacts. But then as they approach retirement, their service contacts start to decline relative to when they entered practice. And this pattern seems to occur in all 4 provinces, with the exception of Manitoba here, and that's mainly because our data didn't allow us to look at those earlier cohorts of family physicians. We could only look at physicians in that province back to 21 to 23 years in practice. And so we see the start of the same trend, but we don't see the end of it. But it seems to be following the same sort of trend where physicians are increasing their practice volume to mid-career. Now, this graph is showing what we might expect if we saw cohort effects. So this is not based on any data. This is just trying to demonstrate what we might see in the graph if there were cohort effects. So for cohort effects, we used a comparison or a reference group of 91 to 93. So those are physicians who entered practice in 1991 and 93. That's our reference category. That's where that dotted vertical line is. The 0 represent differences in the coefficient estimates for relative to that reference category. And so if we saw cohort effects that were unique to the most recent cohort of family physicians, we might see a decline in the trend line here below 0, indicating that early career family physicians are practicing at lower service volumes than other cohorts. But this is what we see when we estimate the cohort effects. Basically, we don't see any indication that the most recent cohort of family physicians are practicing at lower volumes than previous generations of family physicians. And we see here, the same results, but for outcome of physician level continuity. And again, we don't see any differences with respect to continuity between most recent cohorts and earlier cohorts of family physicians. So what does this all mean? Well, we basically find that over the 20-year period of our study, median contacts fell relative to the first year in all 4 provinces. There were large age effects for contacts and for continuity, and I didn't show the results for continuity, but they look very much the same as the contacts, which is why I didn't show them. So we have contacts peak and continuity peaking at mid-career. The main difference between contacts and continuity here with respect to age effects is that continuity doesn't tend to decline at the same rate as contacts do. So physicians, even in later parts of their career, maintain high levels of continuity. But most importantly, with respect to our research question, we do not find that changes in contacts and continuity are unique to the most recent cohorts of family physicians. In other words, it's not millennials that are the problem. So we have done other studies, and I'm not going to do these justice in the time that I have, but we did a study on comprehensiveness as well. As I mentioned, we had these 2 indices of comprehensiveness. So the number of service settings and the number of service areas that primary care physicians practice in. And here we just compared physicians in who had practiced less than 10 years or more than 10 years. And We did not find that any differences in terms of how long you've been in practice, in terms of whether you practice in these service settings or service areas. There were no differences in the two indices, in other words, between different cohorts of family physicians. But what we did find is that there was a decline in the number of service settings that physicians practice in from the start of the study period to the end of the study period. So physicians tended to practice, there tend to be fewer physicians practicing in settings like emergency departments and hospitals at the end of the study period compared to the start of the study period. So fewer physicians doing a lot of contacts in those settings, but fewer of them overall. So what does this mean? Well, physicians are practicing in fewer settings in 1999 to, sorry, that's a typo there. It should be, no, not a typo, sorry. Practicing in fewer service settings, 2017-18 compared to 99-2000. There's a drop in service areas that was smaller than in the drop in service settings. So we didn't see the same decline in the number of areas that physicians are practicing in, so whether they're doing mental health or postnatal care. And there's no evidence that comprehensiveness declined faster, at least in the way we measured it among physicians within their first 10 years of practice relative to physicians who have been practicing for 10 years or more. So overall, just to sum up, we do see some period effects. So there's a decline in service contacts or service volumes over the study period. We do see strong age effects. So this implies that when we're doing workforce planning, obviously we need to take into account the age distribution of the workforce. If we have higher concentration of early career or late career family physicians, then we're going to have lower service volume overall because it's physicians in the middle of their careers that are the highest service volume. And while there's no evidence that we can discern around cohort effects, so it's not the millennials that are the problem here in terms of changes in practice patterns, this doesn't mean that there certainly still is value in understanding the practice intentions and choices of early career primary care physicians so that we can improve retention of in longitudinal comprehensive primary care. And that is one of the goals of the qualitative analysis that Agnes will talk about in her presentation.
Great stuff. Great presentation, David. Really, really fascinating. Nice to have a good sort of meaty methods description. That was really interesting. And it's probably, my question probably has to do with my lack of understanding, of in-depth understanding, which of course is kind of hard to get in a few minutes. I'm just trying to reconcile the seeming contradiction between the decrease in volume over time, over the years, which you've shown, with the retaining of continuity. And maybe I'm now, I know I understand continuity is kind of a relative measure. It's the percentage of contacts that somebody has had with a given physician. Maybe that's the answer, but I couldn't help but sort of think that there seems to be some contradictions here. And again, that's probably my understanding that's at fault.
Okay. So I just want to make sure that I understand the question. So there's a seeming contradiction between declining contacts and constant continuity. Is that right?
It is.
Okay.
Yes. I guess that's the shortest way to put it. Yes, correct.
Okay, sorry. Yeah, that's a good question. So I think you did answer it in that the continuity measure is is measuring the proportion of contacts that physicians had with the patients so every patient that saw that physician, it's the proportion of contacts they had in total that were with that physician. So it wouldn't necessarily be affected by total contacts overall. It's just, how many times are they seeing the same patients essentially?
Now, if I can allow myself a follow-up question. So you also said that, the millennials aren't at fault because they're not seeing a lower volume in their earlier stages of practice. So what is explaining the decrease in the total volume of contacts? Is it because the overall physician population is aging and is not being renewed adequately? Is that the reason? That
Well,
would
that's
seem to be the only logical explanation for me, but I don't know, maybe again.
Yeah, that's a really good question too, and it has a complicated answer that we don't fully understand yet. Sorry, I lost the Zoom screen here. So physicians in their early career are practicing at lower volumes than perhaps cohorts did in previous generations. It sounds contradictory to what I presented, but basically what we're seeing is if you take that curve for age or years in practice, and you just applied an intercept change to every generation, so move that curve down a step essentially for every year as we go along the 20 years of our study, you would get a decline for everybody across all age groups, and that's essentially what we're seeing in terms of contacts anyway. So essentially everyone at every career stage is doing less contacts than they used to be. And so it might look like early career physicians are doing less than previous generations, but they're just following the trend that everyone is following. They're just doing less overall. That's sort of what we're seeing. But the reason for that is unclear. What we think we have demonstrated is it's not a unique change to the most recent cohorts of family physicians. But the reason for it could be due to many things. An aging population, physicians are doing more things in their practice that are not reflected in billing information. So they're doing more coordination for their patients in different service settings that may not be reflected in the billing information, doing more lab tests, for instance, that might not show up here. They're responsible for doing ongoing chronic disease prevention and management, which is more complicated now than it was perhaps 20 years ago. And so there are things that aren't reflected in the billing data that aren't reflected in the billing data that would require physicians to work just as much as they were before, but just doing different things. So I think that is likely what is causing it, but the exact reason for it is something we are just starting to investigate. I hope that answers the question.
Thank you. Yes, it did. Thanks a lot.
Okay. Yeah, great response, David. Great question, Lise. Steve and Alan, I see you've got your hands up. Perhaps maybe we can move to Agnes's presentation so she has time, and then bring your question back later. That would be great. And there's some comments and questions in the chat as well. But I seem to think that this is a good segue into the qualitative. So over to you, Agnes.
All right, so same project, same group of individuals. The only difference here for my piece is that we don't include Manitoba. Manitoba joined late and just used the quant part of our study. We felt we had enough interviews. So I'll be focusing on BC, Ontario, and Nova Scotia. So I'm going to do a little bit about the methods, and then I'll dive into our study results. I'll be talking about the practice characteristics of our sample, the factors that influenced how our participants chose to practice, and then I'll do a little piece around focus practice, because that's always interesting to different audiences we've presented to. I'm going to finish with implications that are cross-cutting the quant and qualitative, and then we'll open it up to Q&A to both David and myself around the whole ECPC study. So our research question for the qualitative analysis was, what are the practice characteristics of early career family physicians? And we define those as the first physicians in their first 10 years of practice. And what are the factors that influence those practice choices? As I mentioned, we focused in on 3 provinces and had 63 interviews. And we also did resident interviews, which are above and beyond that 63, but they're not the focus of the presentation today. And we conducted a thematic analysis of our transcripts, and then did a deep dive framework analysis to identify practice patterns and those influential factors. So if you're not familiar with framework analysis, I'm going to just do a little bit of a glimpse of this to show the kind of painstaking work that it took in order to get to our results. So the first thing is we developed a code book. This was an iterative process where we used deductive codes, so codes from the literature that we found preparing our grant, and also codes that are developed inductively from the transcript. So we had a giant team of clinicians, students, research assistants, and PIs that all read several transcripts and identified the themes throughout. And so to answer our research question, we ended up focusing on what is in the red boxes. So current practice characteristics and influential factors clustered around personal factors, training, and professional. So to do our framework analysis, we pulled node reports from in vivo in each of these separate sub-themes, and we did something that looks like this. So it's purposefully done so that you can't read it in detail, and that's because each row in this Excel spreadsheet is an individual we don't want to be identified. And we build a separate spreadsheet for each of those three themes, plus the practice characteristics. And across 63 participants in 3 provinces, we had 3 research assistants that synthesized each cell for us. So that means that each theme was a column, each participant was a row, and we compared across participants and across themes. So we did that by building a almost 40-page framework analysis convention dictionary, where for each influential factor and current practice characteristics, we had conventions that allowed us to synthesize data in a way that the research assistant in Ontario would synthesize the data the same way as a research assistant in Nova Scotia to ensure our data was comparable. Building the dictionary took several months. It's a good thing. I loved our research assistants, and those were fun meetings because we saw a lot of each other. And then they completed the syntheses, and you'll see that, for example, for professional satisfaction, we have a synthesis, and then next to it, we have a quote or multiple quotes that illuminated the ideas that were captured in the synthesis, and this is where we could pull from the paper. So if anybody was considering doing framework analysis, hopefully they've decided to change their mind now that I've shown them that. Just kidding. It was fun. So a few practice characteristics that I want to share with you. Now, these are based on the interview data. So they're self-reported and brought up in response to our questions. So they may not necessarily be complete, but it does give you a bit of a picture of who we spoke with. So we had almost all of our participants had some kind of combination or half of our participants had a combination of community-based. So this is like your typical comprehensive family medicine clinic, and a type of focus practice. So that was just over 50%. 11% of our sample had solely a focus practice, and I'll tell you a little bit more about that. And 38% had solely that community-based practice. A lot of our participants did locum, and so 31.7% locumed, and those included community-based locums and focus practice locums. 60% did not locum at all. And then we focused in on only these participants that had some kind of community-based practice. So those that had a solely community-based practice and those that combined focus and community. And we took a look at that sample. So those in community-based practice, 83.7% were in a group practice. So very few worked in a clinic alone. And we also have payment model here. Now, these don't add up to 100 because participants reported different types of payment models, and many dipped into more than one of these to create their remuneration scheme. So 42.8% had some form of fee-for-service. Then we saw 42.8 had some form of salary, and there's lots of different options that they sort of mentioned as being part of their remuneration that they pieced together across their career. So let's talk about the influences that help drive those practice characteristics. As I mentioned, we found these three main categories, and I'll start with training. So generally, we found that participants tended to like the practice characteristics they were exposed to in med school and residency. Now, that wasn't everyone, of course. Some had negative experiences, but in general, this was a common theme. We found that training had the tendency to narrow scope of practice for some. For example, when trainees were turned off certain aspects of practice, we saw that often in obstetrics. They'd have a negative obstetrics experience, and then they knew they'd never wanted to do that again. They also sometimes narrowed their scope of practice or focused their practice when they saw their preceptors were too stressed in comprehensive practice and they never wanted to work like they did. And then when there was insufficient training that really reduced confidence in providing a service, they didn't feel they had enough skills in order to do it independently. Training also had the capacity to broaden scope of practice. This happened when trainees had exposure to different services that increased their confidence, that then they added on to their practice after. And then also we found that trainees referred to training in rural settings as an opportunity to broaden their scope of practice because they got to see so many different things in that rural training. Personal influences. So we found that in general, participants had a very strong sense of community, and this meant two different things. So first, they really desired a sense of community within their practice, and this influenced where they chose to locate their practice and also the practice model that they wanted to join. They also sought amenities and existing networks in the community. For example, if they had children, then they looked for good schools, and that influenced their choice of location. Participants referred often to their family situation as impacting their practice in diverse ways, which a lot of it meant around their partner and children. So a participant from Nova Scotia here said, so yeah, if I were on my own, if I didn't have him and my kids and family obligations, I might be more inclined to sign on to something and to be working more and have less flexibility, but be getting paid better. For some, high levels of student debt also influenced them to take on more lucrative roles, which tended to be locums, and choose not to open their own practice to take on that additional risk and needing to spend a lot of money on that. Professional influences were also super interesting. We found that our participants selected practice models that satisfied a need for professional control and autonomy. But on the other hand, others chose payment or practice models that provided desired compensation and financial security. And here's where we see a lot of themes around the fee-for-service system. So a quote that we pulled is from British Columbia. This participant said, I think the fee-for-service system in this province is broken. And the only way that you can keep up with other professional options, and here they're referring to like focus practice for a family physician, is to do kind of crappy medicine. And it's disheartening to try to choose between making a reasonable income versus doing a good job. So I didn't make that choice. I picked something else. And then we also found a really strong desire among many of our participants to do meaningful work, and that influenced their practice choices. And this included supporting marginalized populations, wanting to provide care in a particular way, so really valuing longitudinal primary care, for example, and having intellectually stimulating work. And this participant from Nova Scotia says, I don't know that I'd be very happy with a narrow scope of practice, and a rural family practice allows for that, especially because there's a lot more opportunities to get skills outside of the usual. I also want to bring up a study that Manisha Kabir did for us. I won't ask her to present this because I thought that would be not a very nice surprise, even though she's in the audience. But she did a fantastic job. Manisha was my Master's of Science student and did an internship with the ECPC study and conducted an analysis of 22 family medicine residents and 38 early career family physicians that either had a focused practice or had intentions for a focused practice. She found that most had some form of comprehensive practice in addition to focused practice. And those focused practice choices that they made were often for hospitalist and emergency medicine. Factors that influenced the decision to have a focused practice, a lot of it came down to self-preservation within the current system, so ensuring that they don't burn out in their work, having access to a better support system than they felt they would in a community-based practice, and also having training experiences that gave them the skills they needed to have that focused practice. And if you're interested in learning more, Manisha has published the first qualitative study to come out of this work in the British Journal of General Practice. So in terms of policy and practice implications, practice choices, not surprisingly, are influenced by a mosaic of factors. And of course, some personal and professional influences are really beyond the reach of policymakers, but we do need to acknowledge them in our workforce planning. Others present opportunities for changes in physician training and also in related policy, such as practice and payment models, in order for us to help reshape care. We also found that a lot of physicians are addressing system and community needs through focused practice. So they're not focusing practice because they want to make more money or because they hate family medicine, but because there's clear and important gaps in the community that no other physician is filling. So they're stepping up and doing that focused practice in order to meet those gaps. And lastly, to some cross-cutting implications across the whole of our grant. And we're wrapping up our grant now and writing all of our papers. So these are kind of the themes we pulled from everything. So as David said, changing practice patterns among family physicians are not driven by early career physicians, and this intergenerational blame that we hear sometimes tends to distract from broader issues in primary care. We've seen patient visits per family physician falling across all provinces, which coincides with substantial increases in complexity of care and administrative workloads, which we saw somebody mentioned in the chat. And we feel that the blame and judgment toward early career family physicians is damaging, particularly when it's layered with the feeling that family medicine is already undervalued, which we hear a lot. Early career physicians are committed to providing care that meets their community needs, and practice and payment models must support this. So many participants describe training to provide team-based comprehensive longitudinal care and interest in providing this care. But then many of them reported post-graduation that there was really actually limited opportunities to practice in team-based comprehensive care. And as I mentioned, focused practice by family physicians can extend services available to patients, especially if they're complemented by comprehensive models. And lastly, it's important to acknowledge that the family physician workforce is changing, and we need information on the various roles family physicians fill and the demographic changes in order to strengthen our workforce planning. So it's neither realistic nor desirable to expect that all physicians will exclusively deliver comprehensive care. If we pulled all our family physicians from focused practice settings, we would have a lot of gaps and a lot of problems throughout the healthcare system. So we feel that additional resources will be needed to ensure that all patients can access comprehensive primary care. And I'll stop here so that we can have time for questions. Thank you.
Fabulous, Agnes. Very well described, and lots of insights here and lots of questions. So Claire Liddy, then Claire Kendall.
Hi, good morning. So I'm Claire Liddy. I'm the chair of the department here at University of Ottawa for family medicine. Fantastic work, both of you, really impressive. And I'm just going to make a comment that I think, especially in your conclusions, Agnes, you're right on. We just did a large, had a good response rate on a survey on pain points in family medicine in our community, which highlighted administrative burden, complexity of patients, and then also, really importantly, one of the things you said really hit home, that we have reputational problem right now with family medicine. And so our approach was actually, well, we need to, again, elevate the profile of family medicine and really communicate what the value is of what we're doing. And so your comment about, the misdirected blame on the early career family doctors, I think is really important. So great work. I'm definitely going to do a follow-up with you, because I think if you haven't already presented to the primary care branch of Ontario, that would be important to get you showing your data. And it's really interesting also to see it on the national. So I thought the comparative piece amongst the provinces was very powerful. So fantastic work. Congratulations. I really enjoyed the sessions this morning.
Thanks. I'll just echo, thanks, Agnes and David. I'm a family doctor researcher. I know Agnes, David, we haven't met, but beautiful studies, just methodologically so rigorous and pulled everything together. A couple things that shone through for me. One is a study that Agnes, I know you're involved in, where we're looking to see, looking at kind of similar outcomes around comprehensiveness of care and type of practice for family doctors, but also trying to understand what their own social factors are. So using data, we're going to be able to go back and understand, what context they might have grown up in themselves and whether they're an immigrant and things like that. So we're excited about that, and hopefully that will add a little bit of understanding to the findings that you presented. And another is that really shone through for me, just in my role in social accountability, is this idea of how we train people, right? And just the influence that it does have, the fact that rural exposure makes a big difference. And I think it speaks partly to the hidden curriculum that happens in medical school. And I think now in family medicine, like even you mentioning that people seeing us overwhelmed in comprehensive practice is a real turnoff for them. But especially as we look to a third year, right? Thinking about how we want to shape that experience for residents so that they do feel confident to enter the kind of practice we know we need them to, right? And that's just not what we're seeing right now. So thank you so much for such an amazing presentation.
Thank you. And I look forward to your work. That's really going to be continuing and digging into a lot of this. Yeah.
Great. Steve, then Alan.
Thanks so much, Agnes and David. This is amazing work. It's really clearing up things. I would love to meet with you to schedule a meeting. I hope you won't mind if we reach out. I'm the Director of Research at the College of Family Physicians of Canada, and we're right in the midst of working with a colleague of yours, Bill Hogg, to come up with a bit of a framework for measuring comprehensive care. It's not, as you said, David, it doesn't exist right now. There's not a standard. There's a lot of work, and there's a lot of people actually on the call here right now who are doing the work. So I don't know that we've done it in a really intentional and targeted way. I think in your work, there are sort of constructs around sort of access, just having a family, being attached to a family doctor. And then there's concepts of productivity, I see that in the visits, and then there's questions of comprehensiveness, sort of the scope of the things that you're doing. And I think that these things are being measured probably by your study, but they're not perhaps sort of clearly identified. And maybe that's why there is some discordance there. I love the way you're looking at service settings versus service areas, because that's kind of what it is, right? Like the service areas or the service settings, there's a real hospital bias in there. You think about surgical assistants, anesthesia care, doing obstetrics and staffing the ER. Like is it about the hospital setting really? And I think, Agnes, I heard that in some of those comments, that the anecdotes about sort of the really health systems things, like what are the aggravating factors of practice, and there may be a phenomena around hospital, and maybe that's where these period effects, So anyhow, it would be great to meet with you and talk more about the work that you're doing and look at how we could tap into it, frankly, and make use of some of that. So thank you again.
Yeah,
We
happy.
love that.
Yeah, I'd love to do that, and I agree. I mean, the age period cohort modeling that I presented it's not a precise instrument. Our objective was just to answer the question: are the most recent cohorts different, practicing differently? And I think we did that to some extent, but the reasons for the changes over time that we're seeing are still a black box that we need to dig into for sure.
I just shared in the chat a link to our website where we have the contact information. This study was led by Ruth Laverne. She's the nominated PI. So we're happy to also meet with her, and you can reach out to us or to her, and our emails are listed there.
We're coming close to 9 o'clock. Alan, we'll have your question. If you do have to pop off right at 9, please, I can see that Nia has posted in the link an evaluation of rounds. This is an accredited program, so if you can please complete that, that would be great. And if you can stay on for a few more minutes, that's great. Go ahead, Alan.
Yeah, I'll be brief because I do have to pop off to another equipment. I just want, yes, that Agnes and David, congratulations. That's fantastic work. I really, it's just really a comment. I'm a family doctor here at U Ottawa. I'm also a clinician educator at the college. One thing that you probably know, and it's not without its own controversy, is the CFPC is going to extend residency training with the thought that one of the problems of comprehensiveness or lack of it, or lack of us being generalists anymore and going to focused practices, because there's not enough time to train our doctors to do a super complex job. Like we have the shortest residency in the world, and our job as family doctors is incredibly complex, particularly things like continuity of care, doctor-patient relationship. Like you have to want to be a generalist. And I don't, I suppose that the move now is to give us more time to be able to do that. That it takes more than, certainly in my opinion, it takes more than 2 years to be able to put that message through. But yes, I just wanted to make that comment, and again, just to thank you. That's an amazing work, and it's great. Thanks.
Thank you very much. With regards to the issues that we're seeing, our data pulled a lot about systems issues. So we didn't find data about not enough training, not enough years of training in order to do the kind of care they want to do. I mean, I completely understand the need for an extra year, but we don't necessarily believe that that's going to solve systems issues. So like lack of availability of team-based practice when they graduate, or burnout due to complexity of issues. So we can't solve everything with just that 1 year. We need to look at it from a systems and policy level as well, so that we're supporting our family physicians and giving them opportunities to practice in that comprehensive way. That's not just a solo physician with a ton of debt when they first graduate, having no experience running their own business, for example.
Yeah, absolutely.
Well, thank you very much, David and Agnes. Great presentation, fabulous discussion, everybody.